Periodontal cleaning. No, this was atroseptal defect closure. Nothing special here. No endocarditis prophylaxis. Yeah. Put some music. We're flying through these. Hopefully we do well. Good time. Let's see. She has absolute neutrophil count of 600. That's almost severe neutropenia. Severe is below 500. It's moderate, but that's very bad. Hemoglobin is low. Platelet count, urinalysis and basic. Okay, this patient needs antibiotics. You're not sending this patient home. No, no, and no, because cefepime is usually enough for febrile neutropenia, which is what this patient has, and that's it. Let's go to the next one. Always look at the question first. Most appropriate initial management: CT, abdomen, pelvis, depression, screening, exploration of psychosocial stressors, nortriptyline. Probably this isn't the answer. TCAs are usually not the answer. 62 years of age, abdominal and pelvic symptoms. Well, read for yourself and we'll just answer this so you can see how we work over here. Okay, so now new symptoms: 6 week anorexia, diarrhea, 2-kilogram weight loss, takes no medications, everything is normal, mid abdomen standard to deep palpation. So let's see. Change in her abdominal and pelvic symptoms. The patient has been followed for 3 years for medically unexplained symptoms. And she has typical symptoms. Unknown migrating up. This doesn't seem organic or real. Extensive evaluation has been negative, so we're not gonna do a CT here. We're not gonna do white depression. This is more like somatic symptom disorder. Exploration of psychosocial stressors, maybe, but these two might be together. Somatic symptom, before doing that you would do one of these two, so maybe, let's see, psychosocial, it's been negative. Yeah, maybe she's looking for, there's fictitious and factitious, so I would do that one, but it could be B as well. Parenchymal opacity, chest CT shows multiple opacities and nodules throughout both lungs. Kidney biopsy, high dose glucocorticoid is started. Antiproteinase 3 antibodies, that's the C, because 3 is the third letter of the alphabet, so that is a C. So ANCA C is proteinase 3, and ANCA C goes with Wegener's, right? Yeah, Wegener's. So ANCA positive, we have what it is exactly, and ESR is elevated, creatinine is elevated, all that is elevated. High dose glucocorticoid started. What else would you give that not methotrexate? Doesn't sound like it. Mycophenolate, mofetil, doesn't sound like it. I would go with azathioprine or rituximab. Yeah, this don't look good with this, right? That so probably gonna do this one. Let's see what else it says. 73-year-old woman with this hospitalized dyspnea 6 months ago, sinusitis, nosebleeds 4 months ago, persistent dry chronic cough followed by myalgia and distal paresthesia. Yeah, so all this is ANCA positive. So the question is, what are you going to do for this ANCA positive? And it's ANCA C. And yeah, it seems like Wegener's, right? Sinusitis is Wegener's, and the allergies would be, yeah, we know this is Wegener's. We don't know how to treat it additionally to the steroids. Not sure. What sounds better here? No. I'm between this one and this one. Staying with azathioprine. But I would mark this one. Boom. Most appropriate management. Here you have bone mineral density measurement, calcium, calcium supplementation, fracture risk assessment, oral contraceptive discontinuation, therapeutic lifestyle. BMI is 22. When it's above 25, it's a protecting factor. She's 37. She had secondary fracture prevention 3 months ago after surgery for a right distal radius fracture sustained from a fall while she fell down. So yeah, that can happen. What is that? Probably calcium supplementation. No. Fracture risk assessment score calculation. Yeah, that's the FRAX score. Bone mineral density measurement. Yeah, but this one is more comprehensive. This one takes this into account. Oral contraceptive discontinuation. No. Therapeutic lifestyle interventions. I'm not sure. What will you do about that? They're not telling us the patient is at any risky thing, so I would go with this one. I would mark it. It's A or C. Let's move on. Most appropriate management: liver biopsy, serial abdominal imaging, surgical resection, clinical observation. Hepatic adenoma, you just have to follow this in time. Clinical, you won't know if this grows just clinically. 4 centimeters. Surgical resection, no. Biopsy, no. Serial abdominal imaging, I would do. Once again, gonna mark it. Not sure if I can get back to this, but we'll see. Most appropriate additional intervention. So aortic valve replacement and repair, transcatheter aortic valve implantation, no additional intervention. 62-year-old. Okay, so she already went through percutaneous coronary intervention. Okay. Enlarged thoracic aorta. That's it. You have to surgically repair because TAVR won't fix the enlarged aorta. And the stent is bad, so they're probably gonna have to do CABG on top of that. See, CABG is planned. So this is gonna be it. Let's listen to this on the AirPods. ankle brachial index. So might need a calculator. Right systolic, brachial 140. Oh, I need the mouse. That's the mouse. We're gonna try to continue the music here. So let's look at the arms first. Left systolic brachial. There's a huge difference between these two. Dorsalis pedis is fine. These are the same. Right posterior tibialis. Left posterior tibialis a little bit lower. But what's up with the left systolic brachial? I'm not sure what's up with that. Toe brachial index. Toe brachial index. That's a little crazy. No additional testing. Probably there's something we have to do here. Asymptomatic, okay. Those aspirin. Yeah, if the patient is asymptomatic, why are you going to intervene? So probably if there's gonna be a problem manifested, you're gonna see it on exercise. I would probably do exercise because it is affected. You know, there is some, so you can know the manifestation, right? Exercise, ankle brachial index, that sounds probably better. Lower extremity CT angiography, yeah, but they're asymptomatic, so okay. No additional testing is also a good option. Ankle, let's just left dorsalis pedis. So ankle, brachial, it's not that bad. Let's do ankle brachial. 1.17. .8, so I would do that. Too much time on this one. I would mark it, move on to the next one. Defensive medicine isn't a good idea, so it's probably not gonna be an answer on the test. It's gonna be one of these. Shouldn't be an answer. Maybe one of these. Okay. High value care means mean quality improvement. No, that's high value care is not using crap that is not necessary. Ethanol, flumazenil, fomepizole, hemodialysis, supportive care. Hand sanitizer. Okay, that's propylene, ethylene glycol. Let's see, what is it? Pertinent listed ingredients: ethanol and isopropyl alcohol. Patient has a history of chronic alcoholism. On physical examination, normal ANA and gap. The small gap, yeah, because isopropyl alcohol then can give you normal gap. It's not gonna be flumazenil, that's benzodiazepine. It's not gonna be dialysis probably. Supportive care now. I'm going with ethanol because I remember, or is that with methanol? because patient already has ethanol. So how are we going to treat this? Ethanol is not gonna work on this. If it's methanol, I think you do ethanol. It's less toxic. But if you have these two, isopropyl alcohol, maybe it's hemodialysis. Can you dialyze it? Not sure. Let's mark it. Let's probably go with this one. It's A, D, or E. But I would be more EA or D. And of these two, I would go more with D, because if it was they were trying to only be A, they wouldn't mention ethanol here. They're not even mentioning the level. But they are telling me the anion gap is normal. The osmolar gap is elevated. They're telling me that this problem, I think, is isopropyl alcohol. So if that's the problem, what do? Isopropyl alcohol. Do you do ethanol? Maybe ethanol. It's gonna mark this one. Doesn't let me do anything here. Let's try to get in this again. Hopefully it saved it, because I just hit the, yeah. I'm going with, I marked that one. Time remaining hour and a half, we'll change it later. Tolvaptan helps in ADPKD, autosomal dominant. So if they're big cysts, I'll do this one. Small kidneys, multiple cysts. Not big kidneys. If you cysts have internal septations, there are no solid components or evidence of vascular flow within the cysts. Which of the following is the most appropriate management of this patient's acquired kidney cyst? The patient is already on dialysis. The kidneys don't work anymore. So tolvaptan probably won't help anymore. Bilateral nephrectomy? Doesn't sound good, right? Tolvaptan. Annual kidney ultrasonography? That would be, the cysts have internal septation, so they're a little more complex cysts. But there are no solid components or evidence of vascular flow. So they're telling us that the cysts aren't so bad, but they have some septations. Tolvaptan, nephrectomy, and what with that? Kidneys aren't working anymore. Can they degenerate and become malignant? Or no intervention? I think we have to probably do something about them. But I thought tolvaptan was stop progression to end-stage renal disease. So at this point in time, this won't do much. Take out the 2 kidneys sounds a little too crazy. Maybe just follow it up in time. Let's mark that and move on. Ten-year atherosclerotic cardiovascular. .1%. It's not high. Patient opts to follow the recommendation AHA, ACC, cholesterol management, probably lifestyle modification. I don't think this patient should be on any statin with this. No, doesn't need high intensity. Icosapent-ethyl. I think that can help. Omega-3 fatty acid, maybe. No. How about the patient has type 2 diabetes? That's it. Type 2 diabetes is high intensity statin. Or at least moderate. Yeah, that's an equivalent to peripheral artery disease. It's gotta be high intensity statin. Yeah. That's too high intensity. Most likely diagnosis here. Cortisol free urine, normal, dehydroepiandrosterone. So this is an androgen and it's extremely elevated. This is a normal. This is okay. Testosterone is 90. This isn't PCOS because it's too high. This is probably androgen secreting tumor. Not this. Maybe this. But let's see if there are symptoms. This patient is 19. Irregular menstrual cycles and hirsutism have been present since menarche at age 12. Takes no medications. Blood pressure, okay. Remaining vital signs, BMI is 31. Thick, coarse, dark hair is noted over the upper lip. Chin and sides of the face. No signs of virilism are noted. So I think this question bank is a little bit opposing the UWorld question bank, because UWorld said that when this is so elevated, so markedly elevated, let's see what's the normal. Male, female, it's up to, normal is up to 3.3 micrograms. This is 10. Wait a second. Oh, look, female, normal to 8.9 micromoles per liter. Okay, and this is 10.9. It's not too elevated, so I'm using a different reference range. So it's mildly elevated. It has signs of PCOS. It's gonna be PCOS. But when it's very extremely elevated, it's gonna be androgen secreting tumor, and also with clitoromegaly and virilization. Okay, that's it. Okay. Oh, these are risk factors, yeah. LDL is 205. This is familial hypercholesterolemia. This patient definitely needs high intensity statin. Oh, preprotein convertase PCSK9 monoclonal. So usually high intensity statin will lower her HDL here, LDL, by 50%. That would be probably 102, and that is still very high. She probably needs to be lower than that. Maybe that's not gonna be enough. So this isn't the answer. This might be the answer. You want to lower that real strong. Let's go bold. We can go very bold with this one. Most appropriate treatment. It might be any of these three. These two might be very similar, so maybe this one is gonna be the strongest. I'm gonna mark this one. I'm not sure. Okay, so he's doing well. Blood pressure is good, no murmurs. EKG Sinus Brady. Left ventricular hypertrophy, QT interval is 400 milliseconds. Corrected. So that's borderline on a man. Yeah, that's actually, no, prolonged is more than 450 on a male. I think females it's a little, there's more leniency. It's up to 470, 490. Well, it's not 470, it's normal. Early repolarization noted. Echo shows mild dilated LV cavity. Ejection fraction greater than 55% without regional abnormality. Symmetric hypertrophy noted. Left ventricle worth 12. Feeling normal. So this isn't Fabry. This isn't hypertensive. Non-obstructive. No, this is athlete heart. Look at the blood pressure. No. So what can we see here? What are these? Trophozoites? Are these trophozoites? Seen in Trypanosoma cruzi? No, it's not even here. So these are these schistocytes. They look like schistocytes. And the only one here that is associated with a schistocyte would be E. coli. This is in Giardia. Schistocyte be quiet. It should be through E-tech, enterohemorrhagic E. coli with the SUH, Shiga, what is it? Hemolytic uremic syndrome. 2-day history of bloody diarrhea, picnic, swam, physical exam, okay, bowel sounds, diffuse tenderness, no garden. Patient is anemic, usually hematocrit 3 times the hemoglobin, so that's definitely low. Leukocytosis, thrombocytopenia, kidney injury, that's it, E. coli. Which of the following is most appropriate additional treatment? Theophylline, usually not an answer. Piptazo, maybe. Non-invasive bilevel, maybe. If a patient has heart failure, bilevel. There was something specifically in OSA, but maybe too specific. Let's see what's up. COPD, by worsened dyspnea, cough, and increased purine and sputum. Home medications are the inhaled, yeah. Afebrile, normal blood pressure, vital signs okay. 92% on 2 liters. Expiratory wheezing. pH normal. PCO2 normal. PO2 diminished. Flattened diaphragm but no infiltrates or pleural effusions. Treatment is initiated with prednisone and nebulized ipratropium. Duoneb. Additional treatment. So you want to do azithromycin and complicated COPD, but that doesn't seem too complicated, right? Purulent sputum. This isn't the answer. This isn't the answer. This is always gonna be a good answer for COPDers, but maybe one of these two. But patient isn't even airdropping much. We do want a PO2 that is more elevated. Patient can tolerate that worsen dyspnea, but I would be on the fence. What's the cutoff? P to F ratio, 61 over 92. Let's see what's the P to F ratio just to make the math. 61 over 0. No, F. No, that's not it. P to F. So it's 61 over 2 liters would be 0.21 plus 2 liters oxygen would be 0.23, 0.24, 25, 0.25, 244. That would be mild. Mild level, not completely normal, mild. It's not. Why would we just do characters, cough, and increase sputum production? I don't want to give this. I'm probably going with this one because there's a lot of sputum. You give the BiPAP, you might worsen this patient up, maybe. No, flattened. Okay. Let's go with that one for now. Let's mark it. It's marked. Three centimeter right temporal ring. Which of them also appropriate treatment? Penicillin, metronidazole, vancomycin, lumbar puncture, and culture. Tactic needle aspiration or brain lesion. Headaches and right ear drainage. Medical history is non-contributing. Take note. Purulent drainage seen from the right external ear canal. The right mastoid is tender. Oh man, this is pretty malignant otitis media that went through the bone. I think we have to cover with anti-pseudomonal. Yeah. No, not this one. Not this one. Why these? Staph? Lumbar puncture and culture of cerebrospinal fluid. No. Stereotactic needle aspiration or brain lesion. That's a little crazy. Vancomycin. Maybe. Could that be staph? Another one marked. Let's go. Seizure. Right ear drainage. So basically otitis media went over there, and that's usually strep pneumo, moraxella, Haemophilus at least. But this, if it went in there, it's usually, oh, it might be staph. Yeah, pretty bad. This isn't enough. Maybe this one. I'm staying with that one. Oh, what happened? What happened? Yeah, we won't leave this patient on prednisone forever, so that's not the answer. Maybe hydroxychloroquine for dermatomyositis. Not sure. Methotrexate is usually DMARD for rheumatoid arthritis. I think that would be better, but I'm not sure. Another one we're marking. Submit answer. Next question. Nikolsky. No, this isn't. Maybe porphyria. This isn't that. Maybe it's this one. Let's see what it says. Painful sores and worsen with sun exposure. She has no other medical problems and skin findings are shown. This might be porphyria. Intermittent painful sores in sun exposed areas. No. tissue transglutaminase, that's celiac disease. Dermatitis herpetiformis, doesn't look like that. Antinuclear antibody, could be lupus, but it's only there. Discoid lupus, maybe. It's not mentioned. Bullous pemphigoid, not sure. Worsen with sun exposure. Takes no medications. It's pretty bad. Look at these findings. Blisters. Violation. Ulcers. Big blisters. That sounds like it. Let's stay with that one. But I'll mark that one too. No, they're not giving me any clues for this. No, that's it. Let's leave that one. Yeah, this condition is normal, so we don't have to increase nothing. No. Physical therapy, probably. Maybe there's avascular necrosis. Vascular necrosis, check in there. Calcium is elevated, 10.7. There's also acute kidney injury. This patient isn't hypercalcemia discovered during an emergency department visit 5 days ago. Vomiting and diarrhea that prompted her emergency department visit. Was treated for volume depletion with IV fluids. Complete recovery and is asymptomatic. But she still is hypercalcemic and has acute kidney injury. No, you would do PTH, that's the first thing you do. Serum calcium. We already have the calcium. Why do you want serum calcium? We already have calcium. Serum phosphorus. Yeah, you know calcium and you know phosphorus. That would be a good one. First thing always is PTH dependent or independent before going through these others. Ionized calcium, that can help you in acute critical condition, right? So ionized calcium could be emergency department seen 2 days ago, vomit and diarrhea, was treated with volume but made a complete recovery. So this patient isn't in the ICU right now. It was 5 days ago, but has acute kidney injury. So it's B or C. I'm staying with B, complete recovery. Incidental. Oh, this is the anterior pituitary. This can also tell you about it. Urine and serum osmolality, that's associated with the ADH specifically. So let's see. Seen in the ED following normal menstrual periods and no symptoms suggesting an endocrine disorder. So I don't want FSH and LH. Vital signs are normal. All these tests are normal. We already saw cortisol, TSH, free thyroxine. We don't need to do FSH and LH because we know that is fine. We don't need to do urine cortisol. Maybe we want to see prolactin and insulin-like growth factor. It's going to be two things. Prolactin. Yeah, that tells me about posterior, and insulin-like growth factor tells me about growth hormone. It's going to be C or D. Urine and serum osmolality is going to be ADH. But I would probably go with this. Not sure. Achalasia. Jetty syncope, so you have to do something. It's not gonna be this one. Most appropriate, the cardioverted defibrillator. Yeah, wall thickness of 30, damn. Yeah, so you have findings consistent with rest in this. The gradient goes from 24 to 36 during Valsalva. Septal reduction probably, but what you have to do now is ICD. I guess. Yeah. GFR is 24. You can still probably do most of the things. Albumin to creatinine ratio is 1,500, so there's proteinuria. You want an ACE or an ARB? This one is the ACE or an ARB. venous distension. I think you can't do the A's if below 15, but I think you can still do it here. As for lungs are clear to auscultation, 1 plus peding edema. Yeah, you still don't need the Lasix. That's what they're trying to tell you here. Oh, but the patient is on losartan, so you cannot do ACE inhibitor. You already have losartan on board, so that's not the answer. So this is probably not the answer. So maybe you have to do this one. It's gonna be A or C, A or B. Once again, let's see it. Jugular venous distension, S4. 1 plus pedin, they're talking to you. Lower extremities and ankles is pretty big. So they're probably asking you to do Lasix. You do testosterone, you have to check the CBC always. Oh, also this one. At the start of therapy, laboratory results including 20-year-old transgender male, genetic female, identifies as male, so started on testosterone. At the start, you did CBC, electrolytes, lipid panel, normal. Which of the following is the most appropriate test to monitor for therapy-related complications? So this patient was a female. They won't grow a prostate. Rosacea, maybe? Not sure. Persistent facial rash. Sounds like rosacea. Not sure. It's B or C most probably. Eosinophilic esophagitis. Haptoglobin is undetectable. Normal haptoglobin is 50 to 150. When it is undetectable, there's hemolysis, hemolysis marker. That's why the patient has jaundice. That's why the patient is anemic. Although platelet count is normal, I don't know why. There's a lot of reticulocytes. Lactate dehydrogenase is also elevated. So why is this patient having hemolysis? Acute hemolytic anemia, maybe associated to the nitrofurantoin, I'm not sure. Erythrocyte transfusion, no. Plasma exchange, prednisone. There's antibodies. Oh, these are negative. Plasma exchange is for TTP. 1 Willebrand multimer, something like that. Could this be TTP? Maybe I would go with this one's the only one that sounds good. Nah. No. It's gotta be B or E. Let's leave it there. Let's get back to it later. Yeah, I want to stop the hydrochlorothiazide. And allopurinol probably will help, right? You already did, which was treated with colchicine. First gout flare. Well, hydrochlorothiazide definitely is not helping. It causes hyperuricemia. I'll maintain that one. But we also have to start the patient on allopurinol. Could he have had the gout flare due to the hydrochlorothiazide? Maybe. I'll leave that one. What's this craziness? Cafe au lait? Let's see what's this. Triamcinolone is another steroid, so probably doesn't make sense. Ketoconazole. Atopic dermatitis. What should I add to this? Atopic dermatitis. Oh, these are replacing. Mild capillaries. Maybe this. Oh, but maybe this is showing skin thinning. These vessels here, superficial. So maybe you have to change it. Not sure. Let's mark that one. Dumping syndrome. Sleep gastrectomy. She has to eat small. Yeah, that's the answer. Right arm, 90/56, that's pretty bad. The left arm is not obtainable. Damn. That's complicated aortic dissection. And that's probably ascending, type A. Yeah, that's type A here. Diastolic murmur. So yeah, this is surgical because it's type A. No. No. This one. Another of these questions with the ethanol and all that. 29-year-old emergency department after transport found sitting on his garage floor lethargic empty container of automotive coolant. What was coolant? Coolant was propylene glycol. Physical exam, 37, blood pressure, heart rate with patient breathing ambient air, 99%. He arouses briefly to loud voice but is not interactive, so that's not good. Creatinine in 1.3, so acute kidney injury or borderline. Glucose normal, sodium, potassium chloride bicarbonate, yeah, acidosis. Osmolar gap is elevated, lactate is normal. pH acidosis. It is metabolic acidosis with respiratory compensation. And the formula for metabolic acidosis, I think, is the Werther's formula. So it is bicarbonate times 1.5. Bicarbonate times 1.5 is 1.5 times bicarbonate is 12 plus 6. Basically, it's 18. Plus 8 is 20. Plus minus 2. So the expected PCO2 is 18 to 22. And this is 28. So there's concomitant respiratory acidosis. Metabolic acidosis with concomitant respiratory acidosis. And let's see the anion gap, 138 minus the sum of these two. This is 116. So yes, elevated anion gap. What is the treatment for the coolant? Fomepizole and hemodialysis. No, definitely not lorazepam. Not sure these two. I'm here again at this crossroads. I think this isn't gonna cut it. It's gotta be this one or these two. I'll have to review this. Let's go on to the next one. Adjustment to this patient's pain treatment. Mm-hmm. So, tramadol duloxetine won't help. I think we have to do sustained release morphine sulfate. The patient does need the fast acting, but they also need something that will be longer acting so they can control it. So I think that's going to be an answer for that. Yeah, he needs a PET PSMA scan. Which are the following most appropriate treatment at this time? So this is biochemical recurrence of prostate cancer. Androgen receptor blocker is a good idea. Yeah. Testosterone is suppressed. Bone seeking isotope. Bone. PET PSMA. Why bone? But chemo? Yes, the patient will need chemo. It's a recurrence. No. But you have to look for an androgen receptor. The patient already has suppressed testosterone. Maybe this one. It's gonna be one of these two. Probably needle thoracostomy, but sounds are diminished bilaterally. That's weird. Chest ultrasonography would be something at bedside to find pneumothorax. Chest CT, no, this patient won't survive. Not the answer. Removal of central venous catheter, maybe. Heart sounds are diminished. Could this have done a cardiac tamponade? But if you take it out, what, you're gonna kill the patient. Has just been inserted to left internal jugular under ultrasound visualization to start vasopressor. As the catheter line is being secured, the patient suddenly becomes more hypotensive. There are several medications here on board. Propofol, peptazole, vancomycin. Blood pressure is bad. Shock index is horrible. Breath sounds are diminished bilaterally. Heart sounds are diminished. Chest CT. It's directly under ultrasound visualization. Chest ultrasonography is what I would do. No, no. Poorly differentiated carcinoma. Chemo with a cisplatin-based, fluorouracil-based gastrointestinal cancer regimen. Germ cell or gastrointestinal. Stereotactic reading. Alopecia areata. So this is acute. Just give it. Doxy is what you want to give here. Just started. Can be also D, right? Or no? Let's do that one. His BMI is 34, man. You have to lose weight. No. Warning, stiffen less in 15 minutes. Yeah, he can do other exercises other than walk. He can use a bike, stationary bike. He can do other things. Bony hypertrophy of the knee without diffusion or signs of inflammation. Yeah, this is osteoarthrosis. That's what you want to do. Minocycline is a tetracycline. Topical retinoid. Well, patient now has pneumonia. Right lung base. 29-year-old. No. Yeah, this one. Community acquired pneumonia. Why not? Right? I would do that one. That's what I would choose. Nope, no. How the test will perform at the peak influenza season. The test criteria, new rapid Oh, the study was performed nadir in summer when the least amount. Sensitivity and specificity are not affected by prevalence, I think, and these other two are affected by prevalence. How that new test will perform at the peak influenza season, so now it's at the peak. Okay, so sensitivity shouldn't change, specificity shouldn't change. Negative predictive value should lower. No. Positive predictive, yeah, so that's it. Less than 0.01. So we have hyperthyroidism. TSH is decreased and T4 is elevated. Hyperthyroid. Atenol is initiated. Perfect. So now we want to see what is lighting up. So we want to do scintigraphy. Oh, there's still another question. Okay. This question here you can see ST elevation and AVR. ST elevation and 1, 2, 3. But there's also left bundle branch block. So this is complete left bundle branch block, which can alter my interpretation. It is sinus rhythm because there's P wave that is upright in lead 2, 3, ABF, V1, not sure there. Okay, so if this is new, probably angiography. Right shoulder pressure that occurs after walking half a mile improves with 5 minutes of rest. She has no frequency and duration have not changed. Her history is otherwise unremarkable. Frequency and duration, so it seems stable. Paradoxically split S2. Cardiac examination is normal. Normally split S2 is A2P2, so paradoxically means that it's P2A2. Chest X-ray is normal. And we have this. Exercise EKG won't work because this is already, altered at baseline. Coronary angiography now. Pharmacological, yes. No. It's gonna be C or E. Maybe no further testing. 66-year-old woman, not telling us any other history, but women can present atypically. Right shoulder pressure that occurs after walking half a mile and improves with 5 minutes of rest. It sounds like if she's having some weird exertional atypical symptom, I would probably do, and since she has, would probably do a pharmacological perfusion study. Scored 70% correct of 60 questions answered. Okay, that's all I needed. We need to pass the exam. That's all we need, people. I think a 70 is a pretty solid result. Yeah, for me already in the cardiology fellowship. Very busy days. Tomorrow we have to round very early, all that. I'm happy. Let's see what we got incorrect. That's 70%. Like it. Woo! Here, boom. But we were able to get, we did solid. Just don't give up. We need to pass this test to get our ABIM. Show incorrect. So let's see them real quick. Oropharyngeal dysphagia. You guys weren't with me for these first ones, but key points. Let's just see the key points. Common symptoms of oropharyngeal dysphagia include choking, coughing, nasal regurgitation of solids and liquids. Initial evaluation of oropharyngeal dysphagia is modified barium swallow. Okay. Yeah, and this patient has Parkinson's, so that's most probably what they had. Parkinson. That's the answer there. Next question. Oh, don't tell me I'll have to. This is so. Oh, it's such a pain. I'll have to. Oh, we can jump to the next one here. Any episode of hematuria, you have to do a cystoscopy. That's the right answer on the test. You shouldn't be bleeding. Even if you're on dual antiplatelet, you shouldn't be bleeding. So, that's it. Next question. Idiopathic transverse myelitis. Oh no, the answer was spinal cord infarction. Spinal cord infarction can occur as a consequence of hypotension during cardiovascular or aortic surgery. Anterior infarction of the spinal cord typically results in acute bilateral flaccid paralysis. That's what happened here. That's crazy.